Hello and welcome to my presentation about pediatric migraines. My name is Justin Pritchard. The objectives of this presentation are simply to provide a general overview of chronic and acute migraines, their treatment, and ultimately what you should do or consider doing in practice. The prevalence of migraines in the pediatric population is about 9% on average, although once you hit about 14, this number starts to go up, and you start to see a gender difference between girls and boys, where women, or rather girls, start to mirror their counterparts in the adult populations. So the pathophysiology behind migraines in children and adolescents is largely based on adult pathophysiology. There are no actual studies that differentiate between children and adults in terms of pathophysiology, at least not on a fundamental level, although there are plenty of differences between the two, especially in terms of how it's studied. So going forward, it's important to look at the factors influencing the pathophysiology or presentation of disease. These can include genes, environment, metabolism, hormones, drugs. There's actually at least 50 different combinations or types that you can come up with in terms of cause, and it's not very well understood as to how each of these influence the actual migraine itself. In terms of phases of migraine attack, you essentially have the pre-monitory phase, the aura phase, headache phase, and post-REM phase. So essentially, in the pre-monitory phase, you have some sort of sign or symptom. It's usually a hypersensitivity, which can be objectively measured and recognized by someone before they start to have any actual migraine symptoms. The aura phase is an visual it's not necessarily an hallucination or any kind like that, but it's simply there. It can be like a flashing light, it can be a strobing light, it can be a small light that moves across, it can be anything like that. But it may be for the full duration, it may be only before the actual migraine, it may be after, and it's very difficult to say as to what should be considered an aura when it starts to get into the difference in sensation in terms of smell and the associated visual changes with that. There's definitely some controversy around that, but I think the main thing to know from aura is simply it's going to be a sensual disturbance of some kind, which is rooted in the visual. There's the headache phase. It's going to be a moderate to severe headache, which may last anywhere from a minute all the way to potentially days if it's refractory. The post-REM phase, simply the person may feel extreme fatigue, malaise, a huge variety of symptoms after the migraine, which can lead to disability in terms of not being able to do anything after having a migraine that is severe. And also, finally, the medication use and overuse, and also potentially, depending on the medication, withdrawal. Especially if for whatever reason they're using opiates or barbiturates, for whatever reason they really shouldn't be, by the way, then this can really cause the clinical picture to be quite confusing and not clear at all. So, for diagnosis, the primary focus from a pharmacy point of view is simply that when we have a headache or migraine, we want to differentiate it or be sure that it has been differentiated into a primary or secondary headache. If it is a secondary headache, meaning it's going to present with some sort of other sequelae, like neurological changes especially, or trauma to the head, for instance, you want further evaluation before you begin to treat it as an acute or chronic migraine. Whereas once you've confirmed it's a primary headache or migraine, then you can move forward safely. So, diving into the literature for preventative treatments, the first thing to look at would be the CHAMP trial, which is in the handout if you're wondering where that is. So essentially, 2012-2014, about 300 children and adolescents were randomized to receive amitriptyline, topiramate, and placebo. The primary outcome was a 50% reduction or more in the number of headache days. And so what they found is that placebo performed a 61% reduction, topiramate 55%, amitriptyline at 52%. So that's to say, in terms of outcome, there was a null outcome. The active agents did not perform significantly different than placebo, and in fact, they had a more significantly severe side effect profile compared to placebo. So, taking that and going forward, this really caused everyone in the field to say, well, if we are going to do preventative treatment, first off, we need to make sure that we're not harming the patient. We're actually causing a net good. So looking at the data, you'll find that topiramate, valproex, amitriptyline, and propranolol have no significant difference than placebo in the reduction of headache frequency or disability in pediatric populations. And while there are studies that say that they do, when they have been replicated, they've failed to show the same results. So there is no standout medication here. All of these have their pros and cons, and they may be confounded by the fact that because these are existing treatments in adults, depending on the trial was designed, they may not account for the fact that placebo is going to have a high response. And this is just a general trend for migraines, because of the drugs are already established FDA-approved treatments. And we can go into that a bit more towards the end. Another main thing to note is that cognitive behavioral therapy is the only treatment in pediatrics for preventative treatment evaluation that has been shown to have a benefit without an increase in side effects or anything like that. And what they did is they paired it with amitriptyline versus amitriptyline without. And so all that goes to say is that CBT has a benefit, whereas it has nothing to do with the amitriptyline use. That's something you control. In terms of active treatment evaluation, we start to see some actual strong evidence where there's a randomized controlled trial that shows that compared to placebo, sumatriptan and naproxen combination oral tablets, and the zolmitriptan nasal spray better relieve pain at 2 hours, in addition to the reduction in relative frequency and everything else. In terms of moderate evidence, ibuprofen oral solution and sumatriptan, the nasal spray, better relieve pain at 2 hours. And then also, you'll find in general that if they can administer the acute treatment as fast as possible within the very first minute of onset, they're going to have a better outcome, no matter what treatment they use. So, going towards the recommendation for acute pharmacological treatment based on that data. You'll find that because of age restrictions, so for instance, triptans, the vast majority of them are approved for 12 to 17-year-old, and only certain dosage forms also. Although rizatriptan is an exception, but we'll dive into that next. So, focusing on what would be first line, for as young as 4 years old, or potentially even younger, the ibuprofen, 10 mg per kg, acetaminophen, 15 mg per kg, or potentially naproxen. Although the study that threw naproxen in there was simply a comparison of naproxen to itself in combination with a triptan. So, the actual data behind that is relatively weak compared to ibuprofen and acetaminophen, which have both been compared to placebo instead of themselves with another comparator. In terms of the triptans, you'll find that the naproxen combination tablet with sumatriptan has been shown to be efficacious and is recommended the amitriptyline tablet is recommended. The nasal spray of zolmitriptan is also recommended. And then the dissolving melting tablet of rizatriptan is also recommended. And the important thing to note with rizatriptan is that you can use it from 6 to 17 years old. One of the things also to note is that when they fail a triptan, as in no response or very weak response, you simply discontinue that triptan and try another one. And then if they continue to have an incomplete or partial response or no response at all, then you would add ibuprofen or acetaminophen in combination with that triptan, which is part of the reason why you see naproxen bundled with sumatriptan to begin with, because they're already skipping to that step. So, in terms of the recommendation for chronic treatment, you'll find that CHAMP has heavily discouraged the use of any active agent with large side effect profiles, which goes to say topiramate, amitriptyline, propranolol, and everything else. They show no benefit compared to placebo, at least with current data. And that may be because the trials were poorly designed or whatever else. But if a patient does have more than 4 headache days a month, then you could consider prophylactical therapy. Because one of the main pitfalls of all those trials is that they all excluded patients with severe migraines, meaning like the worst possible clinical picture, where they're going to be debilitated more than 15 days a month, or whatever else. Those are the type of patients which could potentially benefit from being put on a trial of topiramate or amitriptyline for 6 to 8 weeks. And that would be the lowest dose possible. But again, this is not going to be necessarily a standard of care. This is going to be tailored to that unique patient scenario for the maximum benefit, weighing in the risk and potential harms. So, in conclusion, there is a weak amount of evidence for prophylactic treatment in what I would call a normal patient or a usual patient presenting with chronic migraines. In severe cases, again, where they have more than 4 day or headache days a month, then you could consider starting one of the active agents at the lowest possible dose for a trial, and you're going to be evaluating it with the benchmark of a 50% reduction in those days with that agent. And if it doesn't achieve that, then you may as well be giving them placebo. For the acute pharmacological treatment, the mainstay is ibuprofen, mostly going to be an ibuprofen suspension. You're going to see that everywhere, and it's actually a proven treatment. There's at least 2 randomized controlled trials that show that it is at least superior to acetaminophen and placebo. So, one of the main problems, just looking at the actual data, is it's really hard to interpret some of these results because they didn't use a proper crossover design or any sort of lead-in with a single blind placebo to mitigate the high placebo response, which is found throughout all of these trials. So it's something to seriously consider for any trial that's designed in the future, or a trial that you might try in your own hospital or protocol, whatever else. In terms of future treatments, there is a prospective anti-calcitonin gene-related peptide monoclonal antibody, which has been used in adults and found to be efficacious, but it's not been studied in children or adolescents yet. So, something to look forward to. Perhaps we'll have data on that soon, maybe a year or 2. But overall, looks good.